We're going to welcome questions, comments from the peers, and then the faculty.
Yes, thank you very much.
Actually, is a peer or a faculty?
Oh, yeah.
You are both.
For every day.
Okay.
You can hear
Okay.
You are all kind of questions from
the peers first and then the faculty.
Oh. Let me maybe hold on a bit.
Okay, it looks like, because I want us to keep time now that we're starting a bit late. So if there are no questions from the peers, actually, please go ahead. Okay.
Yeah, so maybe I just wanted to get a better understanding. There was a statistic gap.
Yes.
33% of patients have not sort of had hypertension and and viral suppression. Are those the people you are focusing on, or you are collecting information on all of them and trying to do an analysis? So it's not very clear, because when you say predictors should precede the outcome. I'm trying to understand. You are following up these people who have not controlled and those who have.
Yeah, so we look at both, but with the main focus on those who have not controlled and try to understand what led to that, but also follow them over these periods and see, are they improving in terms of control, or those who have controlled that even sustaining it over that time.
Yeah, the fact that they are starting, they are not controlled.
Yes.
And the other ones and controlled. And you are following them up.
Yeah, 18 months.
You see, what is it that is in these people who are not controlled, what predicts not, because they already, by the time already they have the outcome. So if you're trying to look at the predictor should precede the outcome. But these people who are getting them when they have already, so maybe there may be factors associated, maybe not the effect. I'm trying to understand, maybe it's not very clear within that.
That's why I'm here, I need some guidance. I mean, it's like assessing factors associated with non-control.
Yes, more factors, but when you go ahead, predict.
Yes.
You are predicting something to come. But here we are starting with people who have not controlled. So maybe what we have predicted where outcome now happen.
So I actually share your sentiments. I think, given that you've done the baseline study, and in this, I think you're looking at people who you have two groups of people. There are some who were hypertensive at some point, but by this time when you've done the analysis, they have suppressed. Forgive me, I'm more interested. Often I'm dealing with they are controlled.
Yes,
They're controlled. I don't think you can suppress them.
Yes.
Suppression and control.
Okay, yes. But but then there is another group that either are suppressed or are not suppressed, but they have hypertension. So I'm thinking that maybe at that point you have to pause and say, okay, what group am I interested in following for the next several months or several years? And my feeling is that probably you're looking at the group that has not controlled their hypertension. And then that is where you're going to start saying, if they are not controlled, what are the barriers? And what are the barriers? And then once you understand those barriers, then you come up with interventions and then you follow up to see if the intervention is going to work. But it has to be, I think it should be one group, a selected group that we are going to follow. Either they are not suppressing their viral but also not controlling their hypertension. Or they are, otherwise it's going to, for me to look so dim and so good that I'm having difficulty.
Yeah, thank you very much, and thank you for those questions. I think they helped me to clarify.
Lillian, is yours related?
It's a bit related, yeah. Because from what I'm hearing, you're doing two studies. There's a non-implementation sciences study, which is where you have your baseline and following them up for barriers and the like. But what is not coming up here for me is the implementation sciences study. Are you looking at coming up with a new intervention? Are you studying an intervention that's already going on? At some point you mentioned a novel something that didn't also come out clearly. So the implementation sciences part of your study hasn't really come up. Because what intervention and what gap are you looking at and how are you going to deal with the gap?
Yeah, thank you very much. So we are going to look, I'm going to look at that 33% control. And then for the 33%, I want to go back to the different clinics because you see the control is also different at a different level. That 33% is overall, but some clinics will have 40%, others will have even higher, and then others will have like 70%, so the average is 33%. So I am looking at it at multi-system level and the patient levels.
So what I'm sorry for interrupting. So are you looking at whatever it is that has led to the control or non-control? Because that is what you should, that implementation is what you should be studying.
Yes.
What is it in those clinics that have led to the control or the non-control? And so what is the gap if it's a non-control? And that's what you should actually be studying. Yeah, I don't know that makes sense, but it hasn't come out that is what you're doing.
Okay, maybe there is two things here. I see an epidemiological study. But there is implementation, you mentioned it, like looking at your preceding model and the factors. But then the objectives are focusing more on epidemiology. Whereas the key issue here is more to look at the implementation gaps. So, and that's the differentiation between is it epidemiological, is it implementation science? And I see those two things are a bit
so can you refine that? But what you're trying to do is really to understand what are those barriers and what are also the facilitators, what made other clinics perform better, maybe they could be replicated in another place. And then we look at them at different level. Are they clinic level? Are they at provider level? And also are they at patient level? Although I think that is, I'm also being like asked that is also too broad to look at all the three aspects. You might choose to, yes, especially the clinic and maybe
the individual level, clinic levels, and even patient levels. Yeah, 3 levels. 3 big levels, yes.
Yeah. So, well, you know, I listened to the presentation last time, but this time I came at the tail end. So my understanding is that the past paper is about some kind of description and predictors of non-control. You know that? And you're trying to understand why people do not control. And then using those, or maybe the barriers to non-control. In fact, this implementation science language. And then you're using that to design your intervention.
There is no intervention right now.
Yeah?
The way it is right now, there is no intervention.
There is an
There's no
intervention.
intervention in
There
this.
is an intervention that is going to happen. And the intervention is, like for example, if we go to the health center, like this health center, and we find they are not using those, maybe the algorithm, maybe they are not following the SOPs, maybe they are not doing blood pressure measurements, maybe they are not prescribing medicines, then you retrain them and follow them over time. If it's patients and you ask them and maybe in a focus group discussion and see how many of those have adjusted their lifestyle or have done that were recommended, and you find they have information gap, then maybe you implement a health education, a targeted health education for that period and see if there's a change.
So
if it's Yes.
In the objectives, it doesn't count period, but your study is about maybe identifying barriers and facilitators, like you said, and it's not, we're not sure if you're going to design an intervention that you're going to test. So, yes.
Of course, Fred was asking me how you came up with the intervention.
Yeah.
Because it actually is an implementation strategy. Because in that strategy, you have a list of things that are done. The aids that you give, the algorithms, the enhancement of maybe the diagnosis with blood pressure machines and all. But to evaluate that, you need some contrast. And so it puts you already in a sort of a, you have to set up like some sort of trial. You have to compare before and after. Or you have to have a site without the interventions and one with the intervention. To have the ability to have some causal inference to say that because we intervene here on these parameters with this strategy, it worked or it didn't.
Yeah, which is actually practical because, yeah, as I move along, I also like had the same discussion on David Jones.
I had text you. You know what I suggest?
Yes.
Two things. One is the draft manuscript that it might be good to share with some people here as well. You know, that everybody has seen it.
Just drop zero, just have it this week, yeah.
Because people might have some ideas, and that is at least a step in the right direction. Someone has got to draft zero. Now, I would urge you to write this up. Do you have like a proposal?
Yes, I have a detailed one.
You have a detailed proposal?
Yeah, it's 7 pages. Summary.
But you don't have any local person, any local, even if it is a peer mentor or any...
No, for some component I've been interacted with him during that. But I've not had formal, yes. I've not had a formal allocation.
It might be good. They can bring different...
Yes. I've shared that with Rhoda and
They might bring different perspectives. And you know what? It might be that, for example, this baseline study is adequate for to serve certain purposes. But this intervention, so there's an intervention, the follow-up study, the implementation of a team, would even constitute a PhD.
I know.
Do you realize?
I know.
I mean, you're going to follow up people over 18 months, 10 clinics, with all of these,
10 clinics offers you an opportunity to do a straightforward intervention. If you have it
designed well,
yeah.
it could be a PhD kind of work. Of course, you need other courses. It's not only the study. You need to qualify for the PhD with whatever it takes to do that. But I think it would be good if you find it for that area.
I know Dr. Mukose has made a comment. I don't know if you have one because we are running out of time.
Yes, thank you, Fred. Just one comment to clarify on the study population, because it does not come out clear what your cohort is. Because if you are saying you are having a cohort, you want to know what is this cohort. Because it should be within a cohort study, as you know, and you said you are going to follow them up, want to know what is the exposure, and then clearly know what is the outcome. Because here on this slide I see you have HIV patients with hypertension, but later in other slides you are including with and without.
Yeah.
So it's not clear. So you should clarify on that cohort properly, whether in the proposal in your write-up that comes out very well.
Thank you.
Yeah, thank you, Dalsone. For me, what I pick is that I think maybe having the baseline study looked at in more detail and see what is what is the implementation science study that you're going to do after this baseline study. And maybe if you can work out with some people to get some context kind of issues and the implementation science bit might be very helpful. But certainly hypertensive control is a problem in the entire setup. Thank you very much.
Thank you very much for that valuable feedback.